Thank you. All right, all right. Looks like people are piling in. Welcome, welcome, welcome. I know it'll take a minute for folks to get on board. My name is Al Marati. It's my privilege to truly my privilege to be part of this community and conversation within Fall Voice, as supported by the Laryngology Education Foundation and our Fall Voice community through the EBT, so Eat, Breathe, Talk website. Today, we are helping listen and learn and help, we hope, move the conversation forward with regards to health equity within our fields of speech language pathology, laryngology, for our patients, for ourselves, for each other, for our communities. So I'm excited to introduce my fellow committee members and panelists who are helping with this charge, and then also be turning it over to Dr. Chate to introduce the speakers. We have a wonderful, one of our four speakers, Mariah Morton, who's a doctoral candidate down at Auburn, was not able to make it, but we have three excellent presentations. So I just want to, you can see this lineup here. Allison, can you go to the slide that has the donation? I want to remind folks, the Laryngology Education Foundation is the nonprofit that puts on Fall Voice. And the foundation has committed $10,000 a year to be towards funding this sort of work to help ask and answer questions, not just of what's going on, but to do something about it. And it's not going to be immediate. It's not going to be, it's not going to turn things over in one day. But we really want to help move the ball forward as our meaningful legacy. We are the community, the Laryngology Foundation Education Foundation will match community donations, and that's what's happened so far. We're nearly at our goal for the first year, but we're not there yet. So take a screenshot. It's on the website where to donate. I have donated, and I have the fortune that I can do that. And I know lots of folks have been asking how do we do this? So here it is, and there will be a follow-up when we post the webinar about how to make this donation. So thank you for that. Welcome to all the participants. I'm going to turn this over. I'm going to introduce, Rhonda Alexander is one of our community members. She's on. Dr. Alexander is a laryngologist in New York. There's my great colleague, and just been a really a force to shape kind of the vision on this with some of the other members, and of course also with the one and only Dr. Chate, one of our speech language pathology colleagues, faculty at University of Colorado. Dr. J, take it away.
Okay, so the first speaker this evening is Esosa Odigie, and she is going to be talking to us about health literacy and quality assessment of mobile applications for voice and swallowing therapy. So if you want to share your screen. And she's a medical student at Cornell.
And feel free to put questions into the chat or into the Q&A function to all our attendees.
Thank you all for having me. It's a pleasure to be here today. So as was mentioned, today I'm presenting on the health literacy and quality assessment of mobile applications for voice and swallowing therapy. So health literacy is critical in underrepresented minority or URM patients. There was a national 2003 assessment of adult health literacy that found that 58% of Black patients and 66% of Hispanic patients were at a basic or below basic health literacy level. This is in comparison to 28% of white patients. Low health literacy contributes to healthcare disparities and also disparities in access to care. For example, those who have low health literacy are more likely to be uninsured, they're more likely to have delayed care and also difficulty finding a provider. Furthermore, studies have shown that underrepresented minority patients are less likely to be represented in medical literature and medical content. And lastly, perceived health literacy is typically overestimated in these patients, particularly in African-American patients. So mobile applications are being increasingly used in all aspects of health, and especially in the field of otolaryngology. Considering that 83% of Black US adults and 85% of Hispanic US adults own a smartphone, there are over 1,000 apps throughout all subspecialties of otolaryngology. Mobile applications can really help to mitigate some of these health disparities in terms of adding some care. However, the caveat to this is that patients do have a heavier burden to interpret the health information on their own while they're using these apps, because providers aren't there to help clarify any questions that they may have. This can increase rates of misinterpretation of the exercises, for example, on the apps, or increase the risk of using these apps. And this is especially for vulnerable populations that have low health literacy. There was one study that looked at mHealth apps, or mobile health applications, and found that only 6% of apps have met the recommended grade level, which is 6th through 8th grade reading level. And also, studies have found that readability score is associated with the number of app downloads. So apps that are easier to read, such as the description, typically had a greater number of downloads. So we're asking the question, can underrepresented minority patients with varied literacy levels equitably access and utilize these healthcare resources, specifically these mobile applications that may be at a higher health literacy? And while a lot has been done to mitigate personal health literacy and empower these patients to increase their own health literacy, the CDC expanded the definition of health literacy in their Healthy People 2030 initiative to also include organizational health literacy. And that is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. This means that healthcare organizations and also those who create apps and those who disseminate health information have a responsibility to ensure that all patients are able to utilize this information and that it is at a reading level for those patients. So the proposal that we came up with was to assess the literacy, quality, and accessibility of apps designed for voice therapy and swallowing therapy. We are using 4 scales to do so, which includes the CDC Clear Communication Index and the Institute of Medicine Guidelines and Strategies for Creating Health Literate mHealth Applications. Those 2 scales are proxies for health literacy and also clear communication. We're also using the Mobile App Rating Scale and the Institute for Healthcare Informatics App Functionality Scale to assess the quality of apps. This means looking at things like engagement and further functionality in these apps. We also wanted to understand the representation of diverse populations in these apps, considering that URM populations are typically not included in medical content. We also wanted to assess the accessibility for patients with disabilities in these applications. And lastly, since a lot of patients will be using this as an adjunct to many of their therapies, we wanted to ensure that these applications were evidence-based. Thus far, we found that most mobile applications have actually lacked representation of diverse populations, and none of the apps that we assessed for swallowing therapy have met the passing score for the CDC guidelines of clear communication, or a proxy for health literacy. So as the use of mobile applications continues to grow within voice therapy and swallowing therapy, we think it's essential to establish appropriate health literacy standards of these applications so that URM populations with varied health literacy levels and low health literacy levels can equitably access and utilize these healthcare resources. So the next step, which we would love your feedback on, is whether to go down, for one, the route of app development guidelines. There are currently no guidelines that direct app development in voice therapy and swallowing therapy. And we also thought about creating a literacy and representation evaluation tool to evaluate literacy and representation in voice therapy apps and swallowing therapy apps. There are some broader health literacy projects that are also going on as this field is booming. And there is one called the AHRQ PMAT score for audiovisual materials that is also a proxy for health literacy. And there's also work out of the University of Arizona in which they're creating an audio tool to assess audio health literacy, and also a text simplification editor in which you can put mobile health information or text into their editor, and they can simplify this information to make it easier to read for those with low health literacy. So we'd love to contribute as well to health literacy. So here are the references, and I'd like to say thank you for listening to me, and any feedback would be greatly appreciated. Thank you.
Right on, right on. Thank you so much. Welcome also to one of our Health Equity Grant Committee members, Dr. Sims from University of Illinois Chicago. Thanks for coming, Dr. Sims. Really great. Dr. J, do you want to take the conversation forward?
Sure. So thank you so much, Esosa. Does anybody have any questions about this proposal that they want to? I guess you can't unmute yourselves, but you can type it into the chat. Or any of our panelists have any questions?
Where is maybe I'm asking stuff you know tons about or on your way to knowing more about. Where is industry on a lot of this? You know, I don't know if that's your area of expertise. I mean, what can we ask of them as a community in terms of the app developers and the things like that? Is that something that's within our purview as well, or?
It's a great question. I think so, because at this point, for many of the apps that we have evaluated thus far, we have seen that actually quite a bit aren't evidence-based. So I think collaboration between industry and also those who have the health information and who can direct some of these therapies would be helpful. So I think to promote collaboration would be helpful.
And is this the kind of, again, I'm really new to this. Is there, I mean, we're seeing some of this in the literature. This is getting into our journals, things like that.
So specifically within voice therapy and swallowing therapy, we've not seen an assessment thus far. There have been some mobile health app assessments in other fields, such as breast cancer, diabetes, but thus far within the field of otolaryngology and specifically within laryngology, we haven't seen this kind of assessment done before.
That is really cool. Dr. Jete, anything from you on your side, like within the ASHA world and other that opportunities that may come up for this?
Yeah, good question. I guess my understanding from a lot of folks who are trying to do more sort of outreach and intervention in rural populations and that kind of thing is that the thing that seems to come up time and time again is access to the internet in general. Like a lot of communities just don't have access to broadband or to even to like cellular service. Has that come up in terms of how you're considering kind of developing what you're using right now?
So we have studied health literacy before, and we've noticed that exactly as you mentioned, rural populations, many people in rural populations may not actually have access to broadband healthcare. So that's something that moving forward, we would also have to consider and really think about. We were thinking more so related to smartphone access itself, how we can help with those who are able to download applications. But we do know that telemedicine can't replace true medical practice as well. So we're aware of that, and hopefully we can find solutions to those problems as well.
And there's a question in the chat from Yumi Sumida who says, or who asks, curious, 6th to 8th grade reading level seems high. What organization recommends this?
Yes, so the previous studies have found that the average American reads at an 8th grade reading level. So that's the reason why that was recommended within the presentation.
I think there was also Dr. Johns asks in the Q&A. I think everyone can see it. Forgive me. Dr. Johns recognizes the importance of the work, said this matters and is forward thinking. I'm sure these pilot data could drive change. How, Dr. Odighier, how do you think it could be carried forward after your initial investigation?
Yes, so we're currently starting right now within voice therapy and swallowing therapy. If we are able to create standards or a tool, as we mentioned, or guidelines, we can hopefully utilize this in other aspects of health applications and just kind of Um,
I don't think so. Oh, what?
There you go, Steve.
but yes, hopefully if we can develop guidelines, we can guide mobile health literacy in other fields as well. So it can become a broader thing.
Adrian Hancock, I think all of us thought 1,000 apps, that seems like a lot. That was, I think we learned that here. So what you can, I'll read it out loud. So shock, there are 1,000 apps in this area. Seems like a rationale for developing guideline standards for those in future apps to be accessible. Along those lines, do you have a collaborator for user-centered design or serious game design, which means games for learning, not just entertainment? I just recently learned of these terms in this area. Is this gamification? I mean, are we close to what you're talking about? Or is that pretty different?
So to answer, I guess the first question, over 1,000 apps within otolaryngology in general. So that was found in one source. And yes, there are actually a few apps that we found within voice therapy where they do use a gamification. We don't necessarily have a collaborator as we are assessing the apps, but there has been an app that has used gamification.
There's another question that came up from Yumi Sumida. You mentioned a couple of tools. Can you provide a quick summary of features and benefits of each?
Sure, I can also share my screen so I can pull up the 4 tools. One moment. Sorry, I'm not sure what's going on with the screen share, but I can just talk about the 4 tools that I mentioned. So first is the CDC Clear Communication Index. That it was developed by the CDC, and that is essentially a brief survey which looks at how clearly is information communicated. It was actually developed for printed material as well. So you can use that for printed material, and then you would rate each material out of a score of 100. And then to pass the threshold for the CDC, which I also mentioned in my presentation, would be a 90%. And then there was also the Institute of Medicine Guidelines and Strategies for Creating Health Literate mHealth Applications. This was formed at an Institute of Medicine roundtable where they came together to create or bring together strategies for health literate mobile health applications. And it also it's broken down into many categories, but it's also another proxy for ensuring that the application is health literate. The mobile app rating scale has been used actually quite extensively in research. That is for assessing app quality. So we're looking at things such as engagement, information, whether studies were evidence-based, also looking at functionality and how well the app functions. So that doesn't necessarily look at literacy itself, but we also thought it would be important to assess how well these apps work, which is why we're also using that in our study. And then also the Institute for Healthcare Informatics App Functionality Scale. That scale assesses functionality on a more granular level. So that asks questions such as, does the app inform? So those kinds of questions that are looked at on a more granular level within app functionality. So we thought that using all 4 of these scales, we'd be able to target many aspects of apps that we would like to assess. And then we also added our own additional questions of representation of diverse populations, which was not included in any of those scales, and also accessibility for patients with disabilities.
Okay, thank you so much for sharing that.
Congrats.
Yeah.
Thank you so much.
Done.
All right. Our next speaker is Dr. Ross Meyerhoff, who is a laryngologist at Henry Ford. And Dr. Meyerhoff is going to talk about assessment and analysis of health disparities among patients with a tracheostomy at an urban tertiary care hospital.
Hi, and thank you for having me speak tonight, and I appreciate everyone's time and interest. I'll be talking about disparities in tracheostomy care based around our center, which is serving as both a tertiary care referral center, but also somewhat of a safety net hospital for the surrounding community. So, as a background, we know that just the presence of a trach alone indicates that this is likely a resource-intensive patient because of the care itself and just as a marker of illness overall. Hospital costs are high, and there are significant post-discharge needs, not all of which are covered well by insurance. And this could include equipment, both availability and maintenance, and depending on the level of need, partial or full-time care assistance may be needed, and that can be a significant out-of-pocket cost, or take a family member or friend to provide care instead of earning another income. Transportation is needed for both scheduled and urgent medical care, and this may be more cumbersome because of the need to transport equipment. We also seen in Detroit that there is evidence that there's an association between housing discrimination and poorer health. And so why look at tracheostomy care? We know that social determinants of health can affect multiple outcomes across different areas of health. Because there's a need to utilize personal or family resources to have quality trach care, those at risk due to social factors are likely to have a worse outcome. And when we talk about the critical nature of the airway, it means that the stakes are higher. As a result, suspect that there's a high likelihood that disparities will be as great or greater in trach care than other health situations. So the general research question is, what is the impact of socio-demographic factors on outcomes among adult patients with a tracheostomy? Specifically, we're aiming to determine if there are racial and ethnic differences in selected outcomes for patients with a tracheostomy after adjusting for socioeconomic and disease factors. And we hypothesize that African Americans are likely to have worse outcomes after a trach than non-underrepresented minorities, non-African American, even after adjusting for measurable disease and social factors. We suspect similar findings may be present for other minority groups and also for non-English speakers, although don't know that the demographic makeup of our population is sufficient to study this. The design is a retrospective review at a single institution. Our data is sourced from the Global Tracheostomy Collaborative database, which is a centralized database, as the name implies, from institutions across the world. And that is through primarily manual input, through manual chart review. This is supplemented by data extracted from the EHR, in our case, EPIC, and that includes both discrete data points and calculated indices. We will obtain survival data from the Department of Health, and then we're using geocoded neighborhood level data for socioeconomic and social determinants of health. The advantage here of a retrospective review is the ability to rapidly obtain a large volume of data, but keeping it to a single institution allows us to get a little bit more detail than using larger databases alone. Selected variables and covariates as well as outcomes are listed here. It's important to note that some of these, like disposition or follow-up care, will be both covariates and outcomes in and of themselves. There are some other data points that I wanted to study that weren't readily available through our databases or EHR extraction, like patient's education level, the education details provided to the patient and caregiver, and home care arrangements. The resources we have available that allows us to do this research is that we are one of the few adult hospital members of the Global Tracheostomy Collaborative. And we have the infrastructure already to do this work through the Henry Ford Health System Health Disparities Research Collaborative. And the director is my mentor in this project. And like other major systems, we have the ability to pull EHR data regarding multiple patient level social factors. Now, going forward after completion of this initial phase is we hope to use our findings to guide prospective study. The prospective study will then allow us to get more patient level detail, since many modifiable factors are more difficult to study retrospectively, particularly regarding things that may not be documented in a consistent form, such as the education provided to the patients and caregivers, the degree of social support, home care, availability of supplies, and things like that. And then, of course, we'd like to be able to use the information gained from this research to design interventions to improve equity. Of particular interest, our health system has an existing infrastructure for community-based care that may allow us to provide more specifically trach care to the community in surrounding 4 counties, actually, to improve outcomes for those that are most at risk. And we are in early talks regarding how to integrate trach care into the mobile integrated health program. And just to help stimulate discussion, and some questions I had is looking at separate groups. I think non-English speakers represent a different group, not just because of things like discrimination, but also just ability to communicate with the healthcare team. Additionally, thought about including women as a separate group, but I think that's a separate area just because of sex differences in laryngotracheal size. So my thought was to save that for something else. And just from the group in particular, what outcomes do you think are of greatest interest? And we'll leave it here, and here are some of my references. So again, thank you for your time, and I look forward to hearing feedback and questions.
Thank you, Dr. Meyerhoff. Before Dr. J runs the next part, I want to welcome Dr. Khosla from University of Cincinnati, who's been one of our driving forces on the committee. Thank you, Sid, for making, I know you just finished another call. I appreciate it. And thank you, Dr. Meyerhoff. Thank you, Marie.
All right. Yeah, thank you so much, Dr. Meyerhoff. I'll kick it off with a question while things are getting going in the chat or the Q&A. So I know at my institution, there is information in the medical records specifically detailing social determinants of health, things like access to food, access to transportation, sort of those more specific questions. And some of those things go in during emergency care, some of them don't. I know now they're asking a lot more questions as people go through, like, bigger procedures and that kind of thing. Is that something that you would have access to? And if so, I think that would be a reasonable place to look within the medical record.
So we do have that. One thing I do see frequently is looking at food security because there's a program to help with that. You bring up a good point. I have not looked in that part of the EHR in particular, and and to see how much of it is readily extractable data. And I appreciate the thought on that. I've noticed just going through data myself and just through general clinical care that it's very spotty. But the fact that it's even there, I think it's worth looking into further. But so thank you.
I have a question for Dr. Meyerhoff, and I don't know if Dr. Kosel or Dr. Alexander, let me know if you want to jump in. I think it was in your presentation, but I wonder what we'll find when we take, if it's possible, to take the socioeconomic data and look even control for socioeconomic data that our African American patients are treated differently, or have different outcomes, or have different processes, or different, I don't know. Where do you think that? Well, I shouldn't ask where you think that's going to land, but will you be able to answer that question?
I don't think so. I think some of that is too nuanced to be able to get from this type of work. I don't know that I'm qualified to really answer that myself either. But I think if we are able to look more on a prospective basis, we're also, and I'd like to also be looking forward in terms of engaging patients themselves, both with more broadly with patient-reported outcome measures, but also other avenues I've explored is patient panels to help guide research. I'm blanking on the term, but we already have that for head and neck cancer. And I think through that type of direct patient involvement, we should be able to help guide our questions more. So it's a patient advisory panel.
Dr. Sims shared something. Sorry. Gotcha. Dr. Alexander, do you want to? Thank you. You look pre-verbal, as we say.
Pre-verbal, I like that. So Ross, thank you so much for checking this out in your patients. So I just wanted to inquire about how you're stratifying. So you're going to be separating African diaspora patients from non-African diaspora patients. Are you then stratifying each group by socioeconomic status and looking at their outcomes, or is it just group and group?
So we don't have the ability at this level to look at each individual person's socioeconomic status. What it's based on is sorry, I mentioned geocoding, but I didn't explain what that is. And so not everyone knows, but basically we're using census tract data based on the patient's census block. And there are actually two available indices, the social vulnerability index and the area deprivation index. And so that is then being applied based on where the patient lives. So it's a surrogate marker. We're not getting exact data on that individual patient.
So that might reflect like median income, median access to resources, as opposed to on an individual level?
Correct.
Okay.
Yeah, so in a retrospective review, again, we don't have that,
Of course.
that type of granular detail. So.
Okay. Do you think you could, so this is retro because obviously the big databases let us go retro. Is there a plan to go prospective so you can control the issue, the things that you want to tease out?
Yes. Yeah. So my hope is that some things may be a little bit obvious going forward, but the goal would be to get more of a broad view based on this retrospective study and use that to help guide our specific questions so that we can be more get more granular with our specific outcomes, since we won't be able to study quite as many outcomes.
Because this is the kind of thing where we can sometimes get into the error of saying that race is a risk factor, when what we need to be thinking about is that race is not the risk factor. The way that people approach that person's race is the risk factor. So positioning this as understanding where those patients are, not just phenotypically and as far as others' perceptions, with the kind of accumulation of their resources going on the forward end, maybe something that can lead us to some stronger information. But looking backwards is how we can start. Yeah, absolutely.
I think also in keeping with looking at social determinants of health as being inextricably tied to history of segregation and systemic racism, we're kind of grouping that as based on that history and not on a, like you said, a phenotypic, or not on a, I would say racial, but racial is a construct in a sense. So we are not trying to associate any race or ethnicity as a risk factor for a disease or an outcome. It's about looking at where we are as a society and how that's led to differences in outcomes.
I would just
add, that right. Yeah.
Oh, sorry. Add to Dr. Alexander's point that it might be worthwhile to even consider doing something like looking at a cohort in Detroit and looking at a cohort of African-American patients in Ann Arbor. Because then I think that helps get at, is it education? Is it socioeconomic status? Is it, some of those cultural backgrounds that are things that we can change, that are not race-based, and comparing a cohort of patients in a similar geographical area who are, both of those cohorts are African American, may help tease out some of those questions. I mean, I know that if that's not your institution, that might be more work, but I'm just thinking in terms of that. I believe is a strategy that would help us not fall into conflating some of the issues that sometimes get conflated.
I think, well, we have a good relationship with the team at University of Michigan, so there is an opportunity for that. One concern I also had with our the way the makeup of the hospital is that the patients that are coming from a greater distance are inherently sicker because they're outside referrals, whereas the people that are coming locally are full spectrum of, if that's the closest big hospital, that's where people go. So in terms of controlling for that, I've spoken with Dr. Joseph, who's an epidemiologist, and tried to, as we comb through data, how to essentially separate these two groups. But I don't know if anyone has any thoughts.
Hey, Dr. J, we do have one more video to play. So I want to say one thing that, again, not at all in contrast to the important paper that Dr. Odie gave, but one thing that's an advantage of doing some work like trach work is that it's money and hospitals care, and getting support in terms of getting resources outside of this is valuable, and there's a lot of scholarship. So all these areas need to be built on, but I'm excited, grant or no grant, that this work is being done. I think you're going to make a difference, both of you.
Okay. So our last speaker is going to be a recorded talk, and that speaker is Geneva Main. Geneva is a speech language pathologist. She is a current clinical doctoral student at Kean University. And she's going to be talking about an investigation into the relationship between social determinants of health and functional voice disorders. So hopefully we can share that video.
It's 4 minutes long, just for folks. They're not
I'm proposing an investigation into the relationship between social determinants of health and functional voice disorders. This is research that I'm conducting with my advisor, Dr. Sarah Patton, at Kean University in partial fulfillment of the requirements for clinical doctorate in speech pathology. Rationale is functional voice disorders are functional neurological symptoms disorders with four DSM-5 criteria, including one or more symptoms of altered motor or sensory function that are incompatible with recognized neurological and medical conditions and are not explained by another medical or mental disorder and which cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. They've been historically called conversion, psychosomatic, or somatoform, medically unexplained, or functional disorders. But demonstrating psychogenesis is difficult because of limited disclosure. People don't always disclose distress, trauma related to functional neurological symptoms disorders. Patients with the voice disorders have noted adverse traumatic or stressful life experiences preceding the onset of voice problems. And trauma rates are generally found to be higher in people with functional neurological disorders when compared with healthy and organic disorder control groups. Janet Baker found that 41.1% of women with functional voice disorders experience physical violence. 30.1% found of women with functional voice disorders experience sexual abuse. But I don't know if any studies looking at discrimination or other social determinants of health. Violence, sexual abuse, discrimination are all social determinants of health, which are conditions in the social, physical, and economic environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes, and which contribute to illness, healthcare utilization, adherence to treatment, and patient outcomes. Adverse childhood experiences such as sexual abuse or physical abuse falls within the education, access, and quality domain. And discrimination, racism falls within the social and community context domain. The goals of the research study are to use a gender and race conscious lens to explore the social determinants of health that may impact patients with functional voice disorders. A gender conscious lens will be used because women disproportionately seek voice care when compared to men. And a race conscious lens will be used because the racial and ethnic minorities are more vulnerable to social determinants of health than whites. They are underrepresented among those who seek care for voice disorders, are more likely to delay care, and are more likely to struggle with adherence to treatment recommendations than whites. So the hypothesis is that there is a relationship between traumatic stress and voice disorders in women. And the null hypothesis is that there is no relationship between traumatic stress and voice disorders in women. The research questions are, do patients with voice disorders have significant histories of adversity, stress, and or trauma? What is the relationship between adversity, stress, and or trauma and voice symptoms in patients with voice disorders? Do differences in adversity, stress, and or trauma experienced by patients with voice disorders and the general population persist across demographic groups? And what are the sources of adversity, stress, and or trauma in the lives of minoritized patients with voice disorders? I'm proposing mixed methods design. Component A will be an electronic survey made up of the adverse childhood experiences questionnaire and the trauma symptoms of discrimination scale, as well as the VHI-10 and demographic questions. And then ethnographic interviews of 5 minority women to explore sources of traumatic stress in their lives. Thanks for listening.
Right on. And Dr. Main wasn't able to be here, but she was one of our, she was able to present in Miami. And I know our folks were disappointed due to our AV things, but I'm glad we're doing it today. What do you think, Dr. Jete?
Yeah, well, I'm biased. I love Geneva. Yeah, I mean, I think, and actually, for those of you who don't know, Geneva already, her survey is already out and can be taken by patients. So if you have patients who you think would be willing to fill it out, who have muscle tension dysphonia, something along those lines, that would be great. She's looking for about 600 participants. So by the end of January, which she may need to extend, but that's okay. But yeah, I mean, I think this is a really excellent project. I think it's an area that has not been explored. And interestingly, when Geneva and I have talked about this, I start to pay more attention to patients who come in with primary muscle tension dysphonia or other functional neurological symptoms disorders. And it is interesting. They do talk about trauma. So I think Geneva's onto something. And the lens of race is really important here.
Dr. Khosla mentioned something to me. I don't know if you're in a position to expound on that, or any other panelists.
I think it's phenomenal, but I do think we, I know that trying to get further funding by NIH is not necessarily the priority of this group, but if it is, you got to be very careful to look at the emotional issues and then the race issues. And my only point was that Dr. Masana has done some great work with, emotional issues, and having sat on, over 30 study sections, I got to tell you, mechanism and confounding variables really matter. So if that's what we're looking for, I think, the greatest reason for not getting funded is not understanding where we've been. So I wouldn't discount the work on emotional states, mental things from other investigators who were not investigating race necessarily. But I think it's a phenomenal project.
That is great. That is great. We have 3 exciting projects. That's really cool. And Dr.
Yeah, I apologize for missing it. Everyone hates when I start talking about funding, but that's why you brought me here. And you're
Dr.
more
Khosla, this is the Super Friends, baby. This is the Super
you're
Friends.
more
You
than
need
welcome to
everybody.
kick me off if you find funding boring, but
we need each other. So thanks for coming, and thanks for that perspective. I don't have that perspective, so I need it.
Great. And any other questions for anybody who's presented, I guess, who's here, or any other thoughts that anyone in the audience has?
And while those are brewing, our next steps are 3 presenters today, and they've done their letter of intent, and then we have, I forget, another, Allison will send out a little note just a reminder. I think it's in December for the letter of intent, just to say just short blurb about what you're up to, paragraph or 2. And then the grants, I believe we changed to February 1st, but I'll confirm that. It's my commitment was to have a concise grant. December 1st for letter of intent, thank you. So that's coming up, and all needs to be a couple paragraphs. And then the grant, I believe that we pushed out to February 1. And my absolute commitment is that for our team, and for our, most importantly, our submitters, that we have clear, concise grant process. I want to thank Kara Sauter, actually here from the University of Washington. I want to thank our panelists today. I want to thank Marie, who am I forgetting that isn't on here other than Kara? Oh, Greg Postma, of course. Greg Postma, for being a part of this. There's a couple chats in there. Yes, there's still, thank you, Dr. Alexander. There's still time to submit a letter of intent for this round. Our focus, as everyone has seen, is very clearly defined as African Americans in the African diaspora. That will continue to grow over the years. Our field will, our lens, our vision will broaden and continue to broaden. But this is where we're starting. And this is what we're doing. So thank you for joining us. Thank you, Dr. J. Thank you to all my team. Thank you, Allison Conley. And let's donate. We have not reached our goal for donations. You know, this is all going to get funded, but let's thank you, Allison, for putting that up. We've not reached our goals. I know we will. There's a lot of people who listen to this and make a difference. So thank you. This will be recorded and will be available for rebroadcast or whatever. You can look at it later on YouTube or whatever. Thank you, Allison. Thank you, Dr. J. Thanks, everyone. Appreciate it.
Thank you.
Right on.
Yeah,
Dr. Odigay, welcome to otolaryngology.
thank you so much.
And then you can go into laryngology later. Ross, thank you. Sid, thank you. Dr. A, Dr. Sims.
Yeah, thanks, Sal.
Thank you, Sid. You made it better.
Yeah.
Thank you.
You know, I would think about, there's two ways of writing proposals for the NIH. One is, I want to accomplish this goal, 1, 2, and 3. That has traditionally never been funded. It's funded a little bit more. The second approach is hypothesis. And I really think these proposals need to be hypothesis generated.
Okay.
But that's my view.
No, we need your help. Well, let's shape that into the grant finals. So thank you guys. Take care. Good night.